Good day, everyone. I am Dr. Carlito Altimo Jr., a diplomate of the Philippine Board of Otorhinolaryngology, Head and Neck Surgery. So I am tasked to present to you a basic pediatric anatomy and common pediatric ENT disorders. So first, the pinna, also known as the ear. It is adult size by the age 8 years old. And the tympanic membrane or the eardrum, it is in adult dimension at birth. And the eustachian tube, characterized during uh, infant age, it is characterized as shorter in length, less acute angle. Um, Thus, it allows microorganism from the nasopharynx to gain access to the middle ear space. Thus, pediatrics or pediatric patients, they are prone to develop otitis media. It is approximately 50% of the adult length at birth. And remember this tensor valley palatini muscles. It is actually fully developed, but it is not active. For the middle ear, ossicles, and petrous bone, it is estimated it is also adult in size at birth. And for the mastoid, the cortex is thin, predisposing for the subperiosteal spread of mastoiditis in children. So remember, mastoid pneumatization continues through early childhood. And this styloid process is underdeveloped at birth, making the extratemporal portion of the facial nerve, they are at risk from external trauma, such as in forceps delivery. So let's go to the functions of the eustachian tube. Actually, we have three major functions. First is the ventilation of the middle ear space and the pressure equalization. Second, drainage by mucociliary clearance of secretions of the middle ear. And third is protection of the middle ear from sounds, pathogens, and secretions from the nasopharynx. This one, remember? Okay, you can see in my pointer, this is the anatomy of the eustachian tube of the pediatric patients. So also remember that as the child ages, the angle becomes less acute and the eustachian tube lengthens. But it is coupled also with more developed and mature immune system. For older children, like more than 7 years of age, they are less already to susceptible to otitis media because of the changes in the eustachian tube anatomy. So the basic anatomy of eustachian tube is also medial 1/3 is bony and the lateral 2/3 are cartilaginous. It is in opposite by the external ear canal, which is the medial third is the medial 2/3, lateral 2/3 is cartilage and medial 1/3 is bony. Next is the most narrow. Uh, the eustachian tube has a most narrow at the junction of the bony and cartilaginous portion, forming the isthmus. Sometimes in our book, it is called the isthmus, where the cartilaginous tube extends slightly into the lumen of the bony canal, meaning it is not a concrete border where the cartilage and the bone separates, but it has a overlapping. For the muscles related to the eustachian tube, first we have this tensor veli, the tensor tympani, the levator veli, and the salpingopharyngeus. Remember this tensor veli palatini or the dilator tubae. They function and during the act of swallowing or yawning that causes this muscle to contract and open up to allow pressure equalization. You can correlate it clinically, thus just try to maneuver like we call it as the Toynbee maneuver. You pinch your nose, you close your mouth, and you try to swallow. So many patients did it differently because instead of swallowing, they exert pressure outside. So let's go to the middle ear diseases. Remember these risk factors for pediatric acute otitis media. The early onset of infection is younger than 8 months of age because of those anatomy, because of not, the eustachian tube is less acute, angulated, shorter. And for daycare attendants, grouping of 6 or more infants or children, for the family history of severe or recurrent infections in siblings, craniofacial abnormalities such as Down syndrome, cleft palate, and Cruzon. So for these craniofacial abnormalities, the problem here is anatomical defect. So next is the breastfeeding. For the breastfeeding, because you know, this is where the infants or we get the immunoglobulin, especially the IgA antibodies. Tobacco exposure, smoking in the household of parents, grandparents, and other caregivers. Tobacco exposure, the effect of it is it impairs the ciliary movement of the respiratory tract. And next is immunodeficiency. The most common etiologic agents in pediatric acute otitis media are the following. First is Streptococcus pneumoniae. Next is Haemophilus influenzae, Moraxella catarrhalis, and group A Streptococcus. Uh, Now, the Haemophilus influenza has quite not so much in attention because of the immunization. But for all of this, the most common population for the pediatric acute otitis media is the Streptococcus pneumoniae. Remember the complications of the otitis media. We divide it into intratemporal and intracranial. So remember for the intratemporal is the CHL is conductive hearing loss, TM perforation, speech and language delay, especially for pediatric patients, chronic suppurative otitis media, atelectasis of the middle ear, and this one for during our training, otitis media, this is the most common general surgery that we do is the cholesteatoma, facial paralysis, and adhesive otitis media, ossicular fibrosis, discontinuity, or fixation. For the intracranial, this is actually a life-threatening, especially the most common is meningitis. For the pediatric head and neck, we differentiate the neck masses with the new onset. It depends by location. First, for the midline neck masses, we have this thyroglossal duct cyst. We have the dermoid cyst, the lymphadenopathy, lymphadenitis, sialosyl, sometimes if plunging ranula, sometimes or diving ranula, and the thyroid masses. For the lateral neck masses, the most common is actually the lymphadenopathy and lymphadenitis. Let's go on later on. And differential diagnosis of child with new onset neck masses by etiology, we have infectious or inflammatory, which is the most common is lymphadenopathy. For the neoplastic, for the most common is the lymphoma. It could be Hodgkin and non-Hodgkin's, but for the pediatric, the most common is Hodgkin's and the congenital. uh, neck masses. So the bronchial cleft, cyst, and sinuses. So if you remember your embryology, pediatric patients that presents with neck masses, especially the congenital ones, they are actually derived from this bronchial cleft, cyst, and sinuses. So these are the incomplete closure of the bronchial arch apparatus between the cleft and pouch. Remember the cleft, remember for the bronchial apparatus, it encompasses the cleft, the bronchial, the arches, and the pouch. So it is lined with stratified squamous epithelium. So sometimes they contain other dermal structures such as hair follicles, sebaceous glands, and sweat glands. So this also five mesodermal arches also guides the surgeon if what type of congenital abnormalities such as your bronchial anomalies, because it contains own arterial and nerve supply. Sometimes the pouch, the arch, and the cleft, they have own derivatives. So the bronchial cleft anomaly basics, let's go to this one. Remember that the second bronchial anomaly, it is the most common. It is the most common overall bronchial anomaly, such as cysts, sinuses, and fistulas. These cysts and or sinuses may be found along the anterior border of the sternocleidomastoid muscles. Remember, in the lower one-third of the neck. The tract passes superiorly and laterally to these structures, such as your common carotid artery, and they are superficial to cranial nerve 9, your glossopharyngeal, and the cranial nerve uh, 12. The tract splits, remember, no, that this tract splits the internal and external carotid artery. And the difference between this second bronchial anomaly is that they enter the pharynx close to the middle constrictor and open into the tonsillar fossa. So let's go to the common congenital midline masses. TGDC, they call this the thyroglossal duct cyst. They are present at or below the hyoid bone in the midline, but they are less commonly occur superiorly. The tract leads into the base of the tongue, and infections are, remember, polymicrobial with oral pathogenic flora. The preferred diagnostic modality is ultrasound because, number one, there is no radiation exposure. Number two, it can discern the makeup of the mass. Number three, and identify the normal thyroid tissue. And last one, this is the cyst trunk procedure. This is a procedure in which you remove the cyst, the trunk, and the uh, middle third of the thyroid, of the hyoid bone. The purpose of removal of the hyoid bone is to prevent the recurrence, because the former technique, I forgot the name, but previously they used the technique in removal of the cyst and only the tract. So they found out that there are increase in recurrence. Thus, they proceed to this new technique, cyst trunk, in honor of a surgeon, in which he added the removal of the middle third of the hyoid bone. Next is the dermoid cyst. It is possible to differentiate between the TGDC via needle aspirate. The dermoid has, remember class, that the dermoid has a sebaceous contents, whereas the thyroglossal duct cyst is more fluid and cyst filled. Okay. Let's go to consideration for pediatric parotid masses. Okay. Remember the pleomorphic adenoma, it is the most common benign epithelial tumor. And hemangioma is the most common mesenchymal benign tumor. Okay. And the mucoepidermoid carcinoma, low-grade type and well-differentiated, it is the most common malignant tumor. Let's go to the differential diagnosis of pediatric base of the tongue masses. Okay, number one, if you see a child with a tongue-based mass, so remember this following differential diagnosis. Number one, of course, is the thyroglossal duct cyst. Next is the lingual thyroid gland. So for the lingual thyroid gland, uh, since my residency, I only uh, saw one case for the lingual thyroid gland. So next is the vallicular cyst. So I'm so sorry. So lingual thyroid gland is very, very rare. So next is vallicular cyst, and the last is the dermoid cyst. Let's go for the pediatric thyroid cancer. Remember that it is associated with radiation exposure. This is the only well-established risk factor to develop a thyroid cancer. And the most common type of pediatric thyroid cancer is the papillary thyroid CA. Let's go to the nose and the paranasal sinus diseases. So the differential of a child with midline nasal mass is first the dermoid cyst. Remember, this is the most common. Next is the glioma. Next is the encephalocele and the hemangioma. Remember this sign, they call it the Furstenberg sign. It is the enlargement of nasal mass with crying, straining, and compression of the jugular veins. So it is consistent with encephalocele that communicates with CSF. Okay? So when you see a Furstenberg sign, it is encephalocele. Okay? When you later on when you become a surgeon, ENT or general surgery, when you see a nasal mass, don't decide immediately for surgery. Okay. Let's go to pediatric airway abnormalities that occurs when supine. So next is, remember this abnormalities. Number one, it is laryngomalacia. Okay. Laryngomalacia, it is actually the immature laryngeal cartilages. So tongue-based lesions or collapse, some such as vallicular cyst, micrognathia, or Pierrobin sequence. Pierrobon, sometimes they pronounce as Pierrobon. Vascular compression and mediastinal masses. So remember this one, laryngomalacia. Remember the clinical characteristics of laryngomalacia. First is inspiratory stridor. Notice shortly after birth, worse with crying, feeding, or in supine position. They may exhibit the gastroesophageal reflux, such as they present with arcing of the back and frequent spit-ups. Most cases, they will improve with time as long as the child feeds well and gains weight. And severe cases, they may result for the failure to thrive, apneic events, and cyanotic episodes. So remember this anatomic characteristic of laryngomalacia. One characteristic is the floppy or flaccid laryngeal tissues. This one, remember in the pointer, this is the epiglottis. This one is the arytenoid, and this one is the aryepiglottic fold. So the mucosa of the arytenoids and the aryepiglottic folds and the cartilage of the epiglottis are floppy or flaccid. That's why when you you inspire, when the patient inspire, it it is very floppy and flaccid that it will compromise the airway of the patient. Again, another characteristic is narrowed or omega-shaped epiglottis. Okay, this one. They are also shortened aryepiglottic fold. Okay, this one, shortened aryepiglottic fold. So during laryngoscopic examination, we always have poor visualization because of vocal folds, because of the supraglottic collapse. When they say supraglottic, these structures, epiglottis, arytenoid, aryepiglottic fold, and the false vocal cord, they are part of the supraglottic anatomy. So let's go to the craniofacial. I am just discussing the very basic and the most common for basic anatomy and the most common diseases related to this pediatric anatomy. So let's go to the cleft lip and palate. We have this classification and etiology. The cleft palate may be unilateral or bilateral. They describe it sometimes as complete and incomplete. For the complete, it involves the entire lip and premaxilla. Okay. For the incomplete, the remaining small bridge of tissue, they call it as the seminal band. Okay. This one is a incomplete unilateral cleft. This structure here, they call it as a seminal band. Okay. This is unilateral incomplete cleft. And this is a bilateral complete cleft lip and palate. Okay. Let's go to the etiology. It is actually a multifactorial. It is a combination of genetics, environmental influences, and other. Okay. Remember that 30% of the cleft lip and palate is associated with syndrome, and 50% of cleft palate is associated with syndrome. So the incidence of of cleft lip varies by ethnic group. And remember these teratogens. Number one, alcohol, tobacco smoke, the phenytoin, and the retinoic acid. So the fertility doctor or your OB doctor will recommend a prenatal multivitamins and folic acids. You need to take it several months before to decrease the risk of incidence of the cleft lip and palate. Let's go to the anatomical anomalies in the cleft lip and cleft lip defect. So let's go to orbicularis oris muscle. It is actually a muscle here in your lip, orbicularis oris, with abnormal direction and insertion because they have this continuity of the lip. So they have this abnormal insertion, sometimes abnormal insertion into the nasal spine and to the nasal seal. Okay. We have this prolabial skin deficient. This one is the prolabium. No? Prolabium, you can only see it on the deficient prolabium in bilateral cleft lip. Okay, we have the shortened columella, which deviates to the non-cleft side. So in unilateral, in the cleft side, we have this shortened columella. Okay, and the floor of the nose may be absent, may or may not, and the central portion of the alveolar arch may be deficient. Okay, when you become a surgeon later on, if you're doing palatoplasty or chyloplasty, you assess or you palpate this one, this area. So you will appreciate there is a it's quite step of deformity when you palpate inside here, the gingiva, and let's go to widened nasal tip is deflected to the non-cleft side. This is the widened, sorry, this is the widened, no, widened nasal tip, okay, deflected to the non-cleft side, away, and the septum and the anterior nasal spine are displaced to the non-cleft side, okay. Uh, Actually, you can appreciate it if you are doing surgery for the cleft. Remember the septum that separates the left and the right nostril and the nasal spine are displaced to the non-cleft side. Remember these three characteristics of submucous cleft palate. Okay, submucous cleft palate. Remember this bifid uvula, as you can see in the picture. Bifid. Okay. Zona pellucida, it is described as the translucent zone in the midline of the soft palate. And notch posterior hard palate. Actually, in the picture, you cannot appreciate it. But 1 and 2, bifid uvula and zona pellucida, you can really appreciate in this picture. But for the notch posterior hard palate, you can appreciate it clinically. You know, when you see this kind of patients, you palpate, you know, the hard palate. When you palpate, you can see a depression because this zona pellucida, they call it the translucent zone. There is a deficient soft palate muscles. Let's go to choanal atresia. The incidence is 1 out of 5,000 to 8,000 births. Remember that the 2/3 are unilateral, usually on the right, 50% of unilateral, and 75% of bilateral are associated with other anomalies. Remember that 25% bony atresia and 7% is mixed bony membranous. The severity, remember that the severity of the presentation depends on the unilateral or bilateral atresia. For the bilateral, they present with increased respiratory effort, retractions, and cyanosis. But for unilateral, they may present later in life with unilateral thick rhinorrhea. Let's go to the classification of the microtia. Okay, let's go to the ear. We have a different ear abnormalities, but let's focus on this microtia. For type 1, we have mild deformity with major structure present to some degree, meaning they have their presence with tragus, antitragus, the helix, the antihelix, and the lobule. Okay, crus of helix. So they are present, but we have only mild deformity. Okay. For type 2, we have moderate deformity with major structures present, but with deficiency of tissues. Okay. For this one, we are presenting with type 2 microtia in the pointer. We have presence of lobule. We have the helix, but we have deformed antihelix. Okay. We have the deformed tragus and deformed antitragus. Yeah. So they fall on the criteria of moderate deformity with major structure presence, but with deficiency of tissues. Okay. Let's go to type 3. Type 3, severe deformity. Sometimes they called as the peanut ear. They have few or no recognizable landmarks, and lobule may be present. Okay, this one. Remember, this is the most common, and sometimes they called as the peanut ear. Okay. For type 4 is known as anoxia, meaning absence of ear tissue, no auricle or lobule. Let's go for the tonsillitis and pharyngitis. Remember that tonsillitis and pharyngitis, the most common is actually viral, upper respiratory infection. such as rhinovirus, influenza, parainfluenza, and adenovirus. For the infectious mononucleosis, which is the EBV, and for the bacterial, the most common is the group A beta hemolytic streptococcus. 15 to 30% of children who presents with tonsillitis, the streptococcal carrier may convert to active infection or spread the infection to another person. So, diagnosis is rapid antigen test or throat culture. But if rapid detection test is negative, you can proceed with throat culture. Okay. So the treatment course is approximately 10-day course. Okay. So you only consider tonsillectomy for repeated infections. We have this criteria of paradise criteria, how to, you know, to, the indications of removal of tonsils, like 7 episodes in 1 year, 7 episodes of tonsillitis or tonsillar infection in 1 year, 5 episodes in 2 consecutive years, and 3 episodes every year for 3 consecutive years. Remember, the complication of tonsillitis are scarlet fever, rheumatic fever, and acute post-streptococcal glomerulonephritis. So remember the presentation of the scarlet fever for the rheumatic fever and acute post-streptococcal glomerulonephritis. When you are in the internship, actually, you can see this one in the pediatric ward. This is the most common, actually. You can see scarlet fever, rheumatic heart, and acute post-streptococcal glomerulonephritis. So when you see a patient presentation with tonsillitis and recurrent infections, also you watch out these complications. Okay, thank you. Any question, you can send me through my email, or you can ask directly to Dr. Arik, and we'll relay it to him. Okay, thank you. Any question? I will just answer maybe uh, a day after. Okay, good day and keep safe.